Good evening, everybody, and welcome to this MedEClasses Pediatric Endocrine Lecture Series, which we have started over the last, this is the third session which is going on. This is a program which is basically targeted towards postgraduate and practicing trainees. And we want to cover the entirety of pediatric endocrinology over the time, covering different aspects ranging from right from basics as well as advanced parts as well. So we have already discussed, this is the growth module which is working. We already discussed about short stature, the approach, the basic tools in the form of growth chart as well as bone age assessment. And today we're going to focus on a very important topic of growth hormone therapy, which is relevant. And what we want to discuss today is when to use it, how to use it, when should we not use it, and as well. We are really honored to have Dr. Mahesh, Professor Mahesh Maheshwari, who is Professor in Department of Pediatrics at All India Institute of Medical Sciences, Bhopal. And he has been colleague with me for a long time. And welcome, Dr. Mahesh. And he'll be providing his inputs on that. So before we start, we like to have a few words from you, Dr. Mahesh.
Thank you. First of all, thank you, Dr. Anurag, for taking this big initiative of taking the pediatric endocrinology forward. I think most of the time the PG classes has remained only 3 or 4 classes in 3 years duration. So this is a wonderful opportunity for the postgraduates to learn all the things related with pediatric endocrinology. So that is a great initiative.
A bit about what really growth hormone IGF-1 is. Then I'll talk a bit about role of the classic indications, the growth hormone deficiency, Turner's, and SGA. And Dr. Prateek will then go forward in terms of newer indications about chronic kidney disease, idiopathic short stature, Prader-Willi, and some of those experimental indications. And then towards the end, over the last half an hour or so, we'll discuss about how do we address the questions on a practical perspective, from a pediatrician's perspective, and how we can answer them on an examination perspective. So this is part of the MedEClasses initiative towards increasing awareness about pediatric endocrinology among pediatricians and postgraduates. It's in fact an honor to introduce Professor Mahesh Maheshwari, the professor in pediatrics at All India Institute of Medical Sciences, Bhopal. And he was a colleague of me at AIMS around 20 years ago. And he has done a lot of work in terms of pediatric endocrinology and is part of both Madhya Pradesh Indian Academy of Pediatrics as well as the central IAP in that perspective. Now, all of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information with regards to different aspects of pediatric endocrinology, including e-learning resources which are available on our YouTube channel. And we will be posting all these videos already. A huge content is there, and all these videos will also be available recorded on YouTube. So those who miss that can actually go through our playlist on postgraduate lecture series. There are the MedEClasses learning platform, which has got validated tools regarding pediatric endocrinology and various courses available for fellowship programs, pediatric endocrinology for postgraduates, which you can explore, along with the various free rounds that we do. So every month we do 3 programs. One is overall grand round for advanced topics. The second is more for pediatric postgraduates. And then this is the postgraduate lecture series that we talk about in that regards. You can explore our books at the website and our mobile application. Now, all of us know that the growth hormone releasing hormone, growth hormone, IGF-1 axis is the key as far as the overall control of growth is concerned. The hypothalamic GHRH controls the secretion of growth hormone from the pituitary, which happens in a pulsatile fashion under the influence of growth hormone releasing hormone receptor. And this growth hormone then binds to the growth hormone binding protein to reach its target site largely at the level of liver, where it acts on the growth hormone receptor to cause the production of 3 important growth hormone related peptides, namely insulin-like growth factor 1, IGF-1, insulin-like growth factor binding protein, and acid labile substrate. Now, IGF-1 is the major growth promoting agent, and it is the major factor which regulates growth and the growth hormone dependent peptide. IGF-BP has a very, very important role in actually not only taking IGF from one place to the other, but also to modulate the effect. So if you have a huge surge of IGF-1, your IGF-BP will try to control that the free IGF levels don't go up. And this is very, very important when we talk about growth hormone toxicity. Because we are really concerned that if the IGF-1 levels go really high, there may be a risk of tumorigenesis or malignancy. But because growth hormone increases both IGF-BP as well as IGF-1, the effect is in a way nullified. And that's why growth hormone has not been shown to be a carcinogenic agent, despite the fact that it causes increased cellular growth. Now, IGF-1 then acts on the IGF-1 receptor in the growth plate to cause growth. Very importantly, besides this effect of the growth hormone receptor, IGF-1, there are IGF-1 independent effects which are also there with growth hormone. So growth hormone not only produces this endocrine IGF-1 from the liver, it also produces local IGF-1 at the level of the plate. So there is a paracrine effect. And there is also a direct effect of growth hormone on the growth plate. So therefore, the effects of growth hormone are much more as compared to that of IGF-1. A second big thing to remember is that if your growth hormone is given, growth hormone binding protein will take it to the liver, and IGF-BP will also increase. So overall, the half-life, the effectiveness of IGF-1 will also increase. The free IGF-1 will not go up that much, and you will have a longer plateau with regards to the IGF-1 level. On the other hand, if you just give IGF-1, there is no increase in IGF-BP. You will have a sudden rise on the free IGF-1 level, which may result in a lot of adverse effects in that perspective. So whenever we talk about treatment, or some of you will say that if IGF-1 is the major factor responsible for growth, why don't we use IGF-1? Why do we give growth hormone? The answer to that is very simple, that growth hormone has got effects which are beyond the endocrine IGF-1. There are paracrine effects, there are direct effects on the growth plate, and it also increases the IGF-BP. So wherever is required, growth hormone is the therapy of choice. IGF-1 treatment is only indicated in individuals who have proven growth hormone insensitivity in a genetic setting, or if they are growth hormone deficient patient because of a severe genetic defect in which you have autoantibodies which cause decreased effect of growth hormone. So this is important from that perspective. So now in this perspective, what can we do? We can give growth hormone or IGF-1 as I discussed earlier. Growth hormone is clearly the treatment of choice for growth hormone deficiency. And we'll discuss that it is evolving into role in different other causes in that perspective. IGF-1, the role is only in the setting of proven genetic cause of growth hormone insensitivity and rare condition, as I discussed, of GHD1A, in which the body was never exposed to growth hormone. And once we give growth hormone, the antibodies form and they cause a problem. So whenever possible, growth hormone is preferred. IGF-1 is more toxic because if you give IGF-1 without an increase in IGF-BP, you will land up in problems of very high IGF-1 in that perspective. Now, growth hormone is a large peptide, as many of these hormones are, which are a single chain peptide, which are linked via disulfide bonds at the level of cysteine in two regions. So it's a large peptide. And when you have a large peptide, you actually have to be very careful in their production. So it's basically produced largely in the sense of the recombinant DNA technology, and the technology by which it is produced also has an important factor. It's non-glycosylated, which basically means that its duration of action is less. On the other hand, if you talk about HCG or if you talk about LH or FSH, they are having varying levels of glycosylation, increasing their half-life. So growth hormone is rapidly released and quickly goes off because the half-life is very less. In that perspective, there is a disulfide bond as discussed. Now, similar products are also produced via the different systems. So prolactin is pretty similar. The receptor of growth hormone prolactin also similar, as well as the human chorionic somatotropin and HGHV, largely coming from the placental circulation, also have a similar factor. Now, what's important to remember that while we say that growth hormone, the name itself, or somatotropin, comes from growth, there are various other effects of growth hormone, and the levels of growth hormone would vary at different times of the age. Right at birth, the growth hormone levels suddenly shoot up. This is because of the removal of inhibitory substance. However, there is not much growth hormone receptor, so growth hormone does not do much work. This is a very important point to remember. The intrauterine growth is growth hormone independent. It is largely dependent upon insulin IGF-1, but not on growth hormone. And therefore, individuals who have complete GHD do not have any problems in terms of birth weight, birth size. The failure typically happens by around 6 months to 12 months of life. Now, if you look here, the growth hormone levels suddenly shoot up in infancy and then they remain high during childhood to peak up during puberty. This is very important because that's why you have the pubertal growth spurt. So theoretically, you may consider increasing the dose of growth hormone during puberty. And after that, the growth hormone levels come down, but they do not become zero. So there is always a role of growth hormone even beyond growth is complete. In adolescents between 18 to 25 years, it is important in terms of achievement of the peak bone mass, and in adults in terms of cardiovascular function, in terms of anti-aging and other factors in that regards. And finally, there is a somatopause, which happens around old age when the growth hormone levels become really low. So the levels are low in fetal period, therefore they don't play a role in fetal growth in that regard. There is a rise at birth. As I said, this is because of lack of inhibition. Then the daily production is around 25 micrograms per kg per day, which basically is the amount of growth hormone that you typically need in terms of treatment. This is the phase when it takes place in terms of growth. The levels peak to around 50 microgram per kg per day till puberty. So often people talk about doubling the dose during puberty. We'll discuss about that a bit later. Subsequent to that, important role in bone. Again, the levels are 25 till the bone mass is achieved. And then as I discussed about adipocyte, quality of life, cardiovascular outcomes, and then finally you have somatopause in that regards. So this gives us an understanding as to the main growth effects will be in childhood and puberty. If you want to increase bone mass, you would maybe continue it at around 25 years of age. And beyond that, it will mainly be for cardiovascular benefits in terms of quality of life and other aspects, and theoretically anti-aging, which is more of an experimental thing. So growth hormone was always spiritually derived initially, but this was associated with a significant problem of a prion-mediated Creutzfeldt-Jakob disease, which resulted in the ban of pituitary substances. Luckily enough, the same time there were recombinant technology which was coming in, and in fact, growth hormone was the first hormone which was built via the recombinant DNA technology. And subsequent to that, its role, its availability become much more, because with pituitary, you didn't have that much availability, but now you had extensive availability. It started using in other conditions, which Dr. Pratik will talk about, chronic kidney disease, then Turner's, subsequently long-acting GH has come up, and then more indications like Prader-Willi, SGA, and even ISS are coming up in that regard. So it's a evolving field. But if we talk about growth hormone deficiency, we now have experience of around 60 years or more in terms of growth hormone. It has been shown to be very safe and efficacious in that regard. Now, as I discussed, growth hormone is a large biological molecule. So the innovator brands, which are the ones which are developed for the first time, are available in liquid preparation and freeze-dried preparation. And then we have the biosimilar brands, which are basically have the advantage of having lower cost. But of course, they need to be validated in different studies in terms of similar pharmacokinetic, pharmacodynamic data is required even from their perspective. IGF-1 is also available, and there was a big buzz that it may be a very good therapy in various forms of short stature. But as I discussed, growth hormone does remain the treatment of choice, except for growth hormone insensitivity and somebody who's got anti-growth hormone antibodies in that setting. So now if we come back to our original questions, where all can we give growth hormone to increase growth? The obvious answer is growth hormone deficiency. But we also know that it has a role in Turner syndrome, in children who are small for gestational age, who are not catching up, in chronic kidney disease, Prader-Willi, and ISS. These are the 6 major indications we'll be discussing about. The ones where it is also being found similar is Shock's deletion, which is basically similar to Turner syndrome, Noonan syndrome, again, a homolog, so to speak. And Dr. Pratik will talk a bit about experimental indications like skeletal dysplasia, steroid toxicity, hypophosphatemic rickets, and Silver-Russell syndrome. Now, coming on to the main indication about growth hormone deficiency, we will mainly be using the growth hormone guidelines, which are published by the Pediatric Endocrine Society. They're very, very clear. The most important thing is that the oxology, the height, is the major criteria which decides whether you have growth hormone deficiency, whether you will need growth hormone or not. So a child has to be very short or short and not growing. High standard deviation score less than -3 or high standard deviation score -2 with a low growth velocity. The first thing is shortness is important. The second is the growth hormone stimulation. So we all know that growth hormone is a pulsatile hormone. We cannot use a single basal growth hormone. It has to be a dynamic test, either a clonidine or an insulin, and levels which are less than 5 are diagnostic. Between 5 to 10 nanogram per ml are considered to be partial GHD according to them. And in certain situations where we know that there is a CNS insult, there is a CNS malformation on MRI, there is some tumor, if there are features of GHD and the IGF-1 is low, we can use it. But in all other cases, growth hormone stimulation test is required to prove that there's growth hormone deficiency, and treatment is required from that perspective. Now, dose pretty much comes from what we've discussed already, that 25 microgram per kg per day in childhood, which may be increased to 35 to 45 during puberty. If we want to increase our bone health, again, 25 microgram per kg per day is required. But once adulthood is achieved, the requirement becomes less. It's around 200 micrograms in men and 300 micrograms in women, and elderly, the treatment is less. We largely be focusing about the height-related benefit, which is between childhood and puberty in that perspective. Now, one important thing to remember is that if you have a child who has got a severe growth hormone deficiency, we can actually start with a lower dose. In milder GHD, we may go with a higher dose. So you can have some adjustments there in that perspective and go from that. In terms of puberty, of course, the dose requirement is more. Obese individuals would benefit if we give a body surface area based dosing rather than a per kg based dosing, because that will give you a better information with regards to our overall outcome in that perspective. Now, children who are shorter, who have got lower level of growth hormone, whose parents are taller, who are given a higher dose and treated early, have a better response. Now, this is very, very logical. If your growth hormone is low, you are more likely to benefit. If your parents are tall, your target height is more. If you give more dose, the growth hormone response will be good, and earlier is better. So the key crux is to identify the child early. Second big issue is that if you identify the child early, you will require lesser dose and you can have a better outcome. So the cost will be less, because cost is a major factor, and cost will be less, and that will give you a benefit in that perspective of early identification. We can expect a 10 to 15 centimeters increase in terms of height. Overall benefit in terms of final height, the height SDS would increase 1.5 in a 2-year period. So if you want to follow, first year we expect 10 to 15 centimeters of growth velocity, second 8 to 10, and then an increase of height SDS by around 1.5 in that period. The bone age will be slightly advanced, which you have to monitor. And very importantly, if you want to look at any adverse effects, it is important to see that the IGF-1 levels do not rise very high. If the levels go more than 2 standard deviation score, you have to be concerned about in that perspective. So dose adjustment is required, and usual monitoring is after 1 month and then 3 monthly. Now, if a child on growth hormone is not responding, the first question is whether your diagnosis is right. There could be some other condition which can cause this, like celiac disease or dysplasia. There could be issues related to nutrition. There may be an unmasking of hypothyroidism. This is very important, because once you give growth hormone, there is increased inactivation of thyroid hormone that may unmask it. There may be issues that the patient is actually taking it. Less likely in somebody who's paying a lot of money for that. The technique is appropriate or not. And very rarely, if you have a genetic cause, then whether the antibodies have been formed or not. So most important thing is to exclude celiac, I would say, in that regards, and hypothyroidism. Look for nutrition and adherence, and that will give you the clue in most cases in that perspective. Now, what are the adverse effects? These are the major questions which all pediatricians and parents are worried about. It is a very safe drug. There are lakhs and lakhs, hundreds of thousands of patients who are there on record, whose data has been followed up for a long time, and it is found to be very, very safe. The initial side effect which we see often is swelling, edema, which is largely because of protein retention. One thing which you have to vary, if child complains of headache or vomiting, think of a benign intracranial hypertension, a rare side effect in GHD. Or as I said, you may have unmasking of hypothyroidism, And rarely, because of rapid growth, there may be slipped capital femoral epiphysis. So if a child complains of limp, pain in the hip, pain in the knee, on growth hormone, get an X-ray done, because SCFE is a problem. But this is not really a problem alone with growth hormone therapy. It may happen with hypothyroidism. It may happen with any other cause of rapid growth where it may affect that. Glucose intolerance, very, very rare with growth hormone deficiency. Tumorigenesis, I'll discuss later on. So mainly we're talking about edema and some benign ventricular hypertension. Monitoring for thyroid and rarely slipped capital femoral epiphysis is important from that perspective. Now, one big question which people ask is, growth hormone is a growth promoting agent. Would it cause a tumorigenesis? Now, what you need to understand is that we are mainly concerned about rise in free IGF-1. When you are giving growth hormone, you are increasing both IGF-1 as well as IGF-BP. So the free IGF-1 level is not really increasing. So primary cancer, there is no evidence that growth hormone therapy causes primary cancer. There is no evidence that the recurrence rate in somebody who has a tumor is increased. There's only some concern that if there is a second tumor which is happening, it may happen slightly earlier. Now, this data is also debatable. So at the moment, if somebody has an active malignancy or syndromes which are associated with risk of malignancy, like Down syndrome, chromosomal breakage syndrome, Bloom syndrome, or Fanconi anemia, we avoid growth hormone, and we avoid growth hormone for 2 years post-stable surgery. So if you have somebody who has a craniopharyngioma, you will wait for 2 years post-treatment that will start growth hormone in that perspective. Otherwise, it is very safe. If we look at overall, there are some recommendations coming from the Growth Hormone Society, which basically say that puberty, they don't say that we may increase the dose, but if the height is not increasing, you may give a higher dose. They talk about IGF-1 based titration is not required. Monitoring is more important. And very importantly, there should be a limit. Till when should growth hormone be given? We'll talk about that later. In India and other countries where there are cost issues, we find it difficult to continue it till final height. So the minimum time which growth hormone should be continued should be at least 1 year. Less than 1 year treatment is useless, ideally 2 years. And of course, if you can continue till final height, that's important. But very importantly, once the growth velocity is around 2 centimeters, 2.5 centimeters, stop it, because there will be no benefit from there. Now, if somebody wants to really have a relook with regards to treatment, they can do it later on. And as I said, 12 to 24 months is required in terms of follow-up in that regards. Now, before you start growth hormone, ensure that other pituitary function, and by that I mean mainly cortisol deficiency and hypothyroidism, is excluded, because that can cause a problem. Neuroimaging is essential because you may have a CNS pathology, you don't want to miss it, and there are no contraindications like Downs, Bloom's, or Fanconi syndrome, which is relevant in 1 to 2 years after malignancy. We used 2, but now the guidelines say 1 year also is good enough in that regard. Now, if somebody has a multiple pituitary hormone deficiency, we have to be careful, because if you give treatment, the ACTH deficiency may worsen. So you start off with hydrocortisone at a lower dose, 6 to 8, and your dose may be increased. TSH deficiency, again, you might increase the thyroxine requirement or follow-up, and consider an age-appropriate pubertal induction. So it's not just that you're talking about growth, you're looking at many other factors out there in that perspective, and think about other options. Now, as discussed, ideally, we should continue it till final height. There may be consideration about giving it transitionally to increase bone mass to around 25 years of age, and in adulthood for quality of life, cardiovascular benefit, adiposity, and other benefits. Reasonable to give for 2 years, minimum 1 year. If somebody is not going to give 1 year, there is no point giving growth hormone in that situation. What about puberty? And as we have just discussed, that people used to earlier say that increase double the dose during puberty, but it is not essential. But if somebody is short at puberty or there's a late diagnosis, we may go for a higher dose. The other options are to increase the duration of growth, and this is largely experimental, with the use of a GnRH analog to delay puberty, or aromatase inhibitors in boys, but both of these are experimental. So the only thing which may be considered is increasing dose if the child is not tall at that point. What about the newer options? We now have a long-acting option. A lot of work is going on in that regards. Weekly injections are available. Lot are in the experimental trials. There are considerations of inhaled GH, which has not yet come out, and talks about use of secretagogues, like ghrelin secretagogues, which will increase the secretion mainly for the hypothalamic causes. In that perspective, out of this long-acting pegylated preparations and other preparations bound to albumin, maybe something which will go forward in that perspective. Now, what about transition? Once you have stopped for adult height has been achieved, we can give a wash-off period of 1 month. If somebody has already known multiple pituitary hormone deficiency, imaging shows a problem, there is a CNS insult, there is no need for testing. Otherwise, a repeat testing after a month is recommended using either insulin or glucagon. And if the levels are below 5, we will consider that there is a need for treatment. What about adult GHD? The main treatment is mostly for bones, quality of life, and cardiac risk. It should be considered only after a formal stimulation using glucagon and insulin. Clonidine is not recommended at that age group. The level cutoff is stricter. So we talked about 5 to 10 as partial GHD in children, less than 5 as complete GHD for children and adolescents. For adults, the cutoff is less than 3. The dose is 200 microgram per day. It's much lower as compared to that used in children. For young males, 300 for young females, and 100 for elderly. So the dose will come down as the growth hormone secretion, as I showed, increases with childhood, with puberty, and then starts to come down in that perspective. So we have, which by far is one of the most common causes of short stature in females. If you have, as you discussed earlier, if you have got a short girl with no other explanation for growth failure, do a karyotype. That's important. Now, what has been shown that girls with Turner syndrome are born slightly lower at birth, then they tend to falter. Nearly all of them by around 4 to 5 years of age become below the third centile, and they land up around 20 centimeter to 30 centimeters short in that perspective. So they're slightly short at birth, they have a low growth velocity, reduced pubertal spurt, and 20 centimeters below. So in India, we see a height of around 130, 135 centimeters typically as a final height, which is very, very compromised, and we have to be concerned about that in that perspective. Importantly, these girls don't have a growth hormone deficiency. The problems are more with the SHOX gene, which is controlling the skeleton, the thyroid problem, and the estrogen deficiency. So what is the cause? The cause is mainly low estradiol. There is an intrinsic growth plate problem because of skeletal dysplasia and a SHOX problem. Now, growth hormone deficiency is not there, but if you give a high level of growth hormone, you would be able to overcome the condition. So here it is a pharmacological treatment for growth hormone rather than a physiological replacement, which happens in this perspective. Always be wary of thyroid deficiency, which may be there in this situation. So if we go by the guidelines of the Cincinnati group in 2016, very clearly they say that if the growth velocity is low and there is already a short stature or high likelihood, we should treat. This will happen by around 3 to 5 years of age. There are no additional benefits if you treat very early in the toddler age group. People used to say you start treatment at 1 to 2 years, not much benefit. Most girls present to us very late, by around 8, 10, 12 years, it's already late. But 4 to 5 years is the ideal time we should start. The dose, as discussed for GHD, was 25. Here it's nearly the double. You have to give a pharmacological dose in that perspective. And best would be to have at least 4 years of growth hormone before you start pubertal induction, which may not be possible in many of our patients in that perspective. Very importantly, there is no need for growth hormone IGF-1 testing in that regard. You have to monitor for growth velocity, and you expect for every year of treatment an additional 1 centimeter gain in terms of growth. Bone age will advance, and IGF-1 levels will be higher as compared to GHD, but you want to keep it below +3 standard deviation score rather than +2 as a criteria. There will be a special look at for headache, increasing scoliosis, and limb for slip capital femoral epilepsis. Because this is more of a pharmacological indications, the adverse effects may be a bit more likelihood of edema, more likelihood, around 10 times greater chance of BIH. There was 1 in 1400 to 2000, 3000. Here it's 1 in 400. So look for headache, look for visual complaint. There may be an unmasking of hypothyroidism, which may happen. Again, slip capital femoral epilepsis. Glucose intolerance, again more common, but none of these have developed frank diabetes. So don't worry about this. Monitor glucose if required, and scoliosis may worsen. So be more cautious in terms of overall situations. There is a very high dose. So some people are sure that there may be an acromegaloid phases, but not very common. Increased hand size, increased nevi. These girls already have nevi because they are also growth hormone responsive. They may increase. Very, very rare risk of pancreatitis. So you have to be very cautious in evaluating and treating in that perspective. If you give growth hormone for a longer period with a taller parent, higher dose, and earlier, you will have a better response, which will happen with Turner syndrome in that perspective. One big question, most of the girls who present to us actually present to us with short stature and delayed puberty, presenting late. When should we do our pubertal induction? So ideally, should be at 12 years, but if the diagnosis is delayed, we would expect 4 years of growth hormone response will be better in that perspective, and don't delay beyond 14 years. It's not going to benefit. In girls who are presented very late, oxandrolone therapy may be helpful in that perspective. Pubertal induction should be gradual, 10% of the adult dose, and increase it very, very gradually over 2 to 2.5 years. No role of low dose estrogen in the pre-pubertal age group. So start from around 12 years of age, try to get the periods by around 14.5, go by 10% to small for gestational age. And this is one of the most common indications one can actually encounter because the sheer numbers are huge. Now, if we talk about SGA, we need to differentiate between SGA, which is a single time reading as far as birth weight is concerned, and IUGR, which is a longitudinal phenomenon. So, which means that somebody who is not growing. So, children who are SGA may not be IUGR because they have always been growing fine. And those who are IUGR may not be SGA. So, IUGR is a better term, but because we often have birth weight or length, that's why we use the term SGA. It's a common thing. 1 in 40 will be SGA. 90% of them will catch up by 2 years of age. And of those who do not catch up, they may have early puberty and they will land up as short adults. So this is an important indication where we have to be cautious in terms of monitoring in that perspective. If you have a preterm child, plot on intrauterine chart till term, and then correct for the age till 1 year, after which a normal growth can be plotted and monitored. Now, why are these SGAs short? They have got a high growth hormone in fetal period, but there seems to be an insensitivity to growth hormone. So they have got a growth hormone resistance, but they are waiting to grow. As soon as the environment improves, they want to grow, but they also have early puberty, which you have to be cautious about. The reason why they are not growing depends upon the etiology. So if it's because of the mother's problems like eclampsia, reduced vascularity, infection, or nutrition, the catch-up will be good. The environment is bad. Once they come out, they will do well. If there's a placental cause also, once they go out, they will grow well. These are the 80 to 90% cases. Now, 10% may have a fetal cause like infection, like genetic causes, like syndromes. These will have an intrauterine as well as a postnatal growth failure as well. So this is something you have to be cautious about, and these 10 to 20% will not catch up. If you do not catch up by 2 to 4 years, very, very unlikely they will catch up. And therein lies the role of a growth promoting therapy in that setting, in that regards. Now, again, as we discussed for the Lawson-Wilkins guidelines for growth hormone deficiency, the Cincinnati guidelines, there are also very good guidelines for SGA, which are available, which says first, exclude all the systemic diseases. So do liver, kidney, thyroid, all those things you should do. Work up on nutrition, and then look for contraindication. Now, many of these syndromes, like as I discussed, Fanconi, Bloom's, ataxia telangiectasia may also be SG. So you may be missing them. So identifying them becomes important in that regards. No need for GH-IGF-1 testing, a higher dose than growth hormone, 35 to 70. And then you expect for every year of treatment, you expect 1 to 1.5 centimeters as extra growth. Now, when should treatment start? The Americans are more aggressive. They say if somebody is not catching up by 2 years, height is less, start treatment, while the European agencies talk about 4 years. In settings where nutrition may be a problem and where cost is an issue, I would say definitely wait for at least 4 years. The child is very, very short, you may consider early, but otherwise waiting will be better in that perspective. Very importantly, severity is more important. If somebody is minus 6 SDS, you should start early. If somebody is minus 2.3, 2.4, better to wait for some time. If the puberty is very advanced, there may be a role of GnRH. Mahesh, if there are any points here, we'll take and then we'll go forward from there.
Yes, I think you're absolutely right about the intermittent therapy. There are not very much published data, and whatever data is available, the continuous therapy is definitely better choice than giving the intermittent therapy. But probably in our country, maybe we need to decide on the circumstances. But as the in your presentation also you said that minimum 1 year therapy is actually give you the actual benefit, and you can better convince the parents also and show the results. So in that scenario, maybe they can continue with so the counseling part is more important instead of thinking about planning for this intermittent therapy. Related with the postgraduates, I think there are many questions that can come up from your presentations, that there are starting from that even at the undergraduate level, we used to answer what is growth, how to assess the growth, so definitely assessment. And then, but for the postgraduate point of view, there are questions that can come as a long question also here, as how to the most important thing, the physiology. So that is the most important thing that we should remember, and more focus whenever you are writing an examination question related with the growth hormone. So the physiology part is very important, because that is the answer of your subsequent writing, whatever you are going to write.
What are the metabolic improvements in growth hormone therapy? Dr. Ratnibel is asking. So metabolic improvements are largely in terms of increase in terms of muscle mass and the lean body mass, with a decrease in the fat mass. Now, what we need to understand is that these are much less as compared to the oxylogical benefits. So if we talk about growth hormone deficiency, the benefits are less. But if you have somebody with obesity like Prader-Willi syndrome, as Dr. Pratik said, the benefits may be significant. So there are benefit improvement, and that's why we are using it mainly in adults, largely to decrease the cardiovascular risk, to improve quality of life. But that is not the primary reason why we treat them. Now, Dr. Candy is asking how to treat a child with pan-hypopit but attaining late at the age of 17 to 18 years, and bone age is approximately almost 6 years. This is very, very important. Late presentation of MPHD, we have to first of all look at the bone age, how the bone age is. First of all, always start with hydrocortisone, start around 8 to 10 milligram per meter square per day, then correct hypothyroidism, then start with growth hormone at a low dose. Don't start more than 20 microgram per kg per day. Try to build it up gradually. Be very careful with growth hormone. Once you're giving cortisol and thyroxine, the requirements may go up. And pubertal induction also maybe after some time. So this is a condition which we should ideally not have missed. But once they are presenting, this is the option we can give from there. Now, ideal side of growth hormone generally is the thigh region. We prefer thigh in this perspective over abdomen. And Dr. Rajib is asking about the dose of growth hormone in Turner syndrome. As I said, the dose is higher. It's usually around 40 to 50 microgram per kg per day as compared to 20 to 25 for the growth hormone deficiency. And we can go and have a look at our website regarding various courses which are available, the application and the books.